understand the anatomy of your heart, which I have encouraged you to learn before, the valve, disease makes sense. So basically, we're going to, this is about structural and functional abnormalities related to valve disorders. So it's cover safe and effective environment, management of care. There's some pharmacy related to this, and communication is always important. If the patient's having some type of reaction or something, and the family's there, it's important that we explain to them what to do. As always, medication is important. So basically, if you can relate the pathophysiology to the clinical manifestations and know the diagnostic studies, that's one of our objectives. Describe the collaborative care and the nursing management of patients with valvular heart disease, and correlate the surgical and non-surgical interventions. So if you know what to do nursing-wise, if you know how to do the assessment, and understand the anatomy, it should be pretty straightforward. And I'm pretty sure for both of these lectures, it's probably about, I think it's about maybe 9 questions on the test. So first we're going to prioritize the valves. We have the mitral valve, the aortic valve, the tricuspid, and everything. The only thing we're talking about here is strictly the mitral valve and the aortic valve. The other ones we're not discussing or anything related to that. However, if a person, a lot of times when they, the IV drug users, they end up with problems related to the tricuspid valve, but they can have issues with other valves as well. So basically, from valvular disease, some of it's acquired. So if a patient has a history of rheumatic heart disease, if they were born with some type of heart problem, the valve disease. People are actually born with like slight murmurs, and then as they age, calcification and everything, those very slight murmurs might become more severe, and then they might have to intervene. It can be related to an inflammatory process, and calcification again. The calcification is basically related to the aging process, and because of that, we have compensatory mechanisms. So as I go over these, like for example, if you had a mitral valve disease, what happens? What do you have? You have in between, you have the left aorta, then you have the mitral valve, and then you have the left ventricle. So say you had some type of a problem with the mitral valve, it would be backing up into the left atrium. All right, so you have compensation related to that. We'll talk about the left, because it's backing up, you end up with left atrial dilatation, dilation, and other problems would occur. So overall, some of your assessment findings for many of these. What I encourage you to do, again, when you're studying for this, make a chart, mitral valve and everything, and what's different. Like the murmurs will be different. A lot of times, the backups are the same. It might be a difference between chronic or mitral or acute disease related to that. So if you know that and the treatment and things along those lines. But subjectively, what type of symptoms would you have? Obviously, a lot of this gives you shortness of breath, similar. The reason this is actually after the CHF, because you have a lot, if it backs up, you have a lot of the symptoms associated with CHF. So that's why this follows that lecture. So you're going to have the fatigue, the weakness. Sometimes you just have regular dyspnea. Some people have dyspnea or the exertion. Some people have the nighttime dyspnea, the P&D, chest pain, weight gain, and if you have a history of rheumatic heart disease, again, this can get more severe. Objective symptoms, orthopnea, dyspnea, with mitral stenosis in particular, you have pink tint sputum, murmurs and all of them, edema, restlessness, and dysrhythmias. You can have ventricular dysrhythmias, but the more common ones you have with these are your atrial dysrhythmias. A lot of times it's atrial fibrillation. Diagnostics, again, for the most part, it's like there are your chest x-ray, your EKG, your stress test. So what are these going to show you? The chest x-ray is going to show you the size of the heart, and it's, if there's any left ventricular enlargement or anything like that. The EKG is going to show you if you have any dysrhythmias, ischemia, or if they had a heart attack. And again, it might show you some changes in the T waves, which would indicate a left ventricular hypertrophy. Your stress test is going to show you how that patient responds when they're under stress. So if they're able to take the exercise test, when they wear out, do they have symptoms? I know we were in clinical last week. We actually had a patient who was admitted because while he was on, maybe it wasn't last week, might have been the week before, but at some point, while he was on the treadmill, he got very, very fatigued, and I actually think, yeah, you did have that. So it's going to show you that if they can't tolerate a regular stress test, they might do something with persantin or some type of drug to see. And what they do is they give them that drug to see how it goes through the heart, to see if it stresses the heart or anything like that. How they evaluate you, does the patient get tired? Do they get more fatigued? Those type of symptoms. Your TEE, what's the TEE going to show you? If it's progressing, it's going to show you clots, if there's any clots in there, and it's going to cause you valve structure. A lot of times they give you the TEE because if from the illness you're starting to get more symptomatic, they might want to do an intervention. But there's certain interventions they can't do if the patient has a history of clots. So the TEE is going to tell you if there's any clots or a history of clots or pre-existing clots. Your MRI, the gold standard is the CT scan, but they will probably try to do other tests, like the stress test or something, because even though it's a gold standard, it's more expensive. So obviously, they don't, unless they definitely have to do it, they wouldn't do it. And of course, your cardiac cath, because it's going to show you blockage, the degree of blockage, and exactly where that blockage is. Because sometimes with these valves, if they have blockage on top of the valve, they'll do the valve replacements at the same time they do the CABG. So, obviously if the CABG is going to take 3 hours, you're probably out adding a good hour, hour and a half. So obviously they have to look at certain things, how strong is the patient, can they undergo this, because it's a very taxing on the heart. Again, I'm sure she told you when they do the CABG, what do? They literally open up the heart, they use a saw, they open up the heart and and have it open, and they put you on the bypass machine. You shouldn't be on the bypass machine for a long period of time. They give you a little bit of heparin, a little bit, because they don't want your blood to clot, and that's going in as well. And then they're doing the bypass based on what it is, because they've done the catheterization already before. So say the left vein is blocked and the left vein is pretty significant, they have to find a way to bypass that so that area of the heart can still get circulation, because once that area is dead, it's dead. Okay, so if it's still alive, once it's dead, it's dead, but if there's anything still alive, they can bring that back. But what they want to do is find a way to bypass that area so the patient can still be perfused to some extent. So what we have in both of these, in the mitral valve and the aortic valve, we have stenosis and regurgitation. Stenosis is just that, it's a tightening. So it's a narrowing of that area. And because it's narrow, as much blood that would normally go through can't get through, because again, I'm gonna go back to the straw. If that straw, again, if we're eating whatever thick shake you like, if you're drinking that thick shake and there's only a little area, you're only gonna get a little area up. Whereas once that shake starts to melt and everything, you can get a whole lot up because it's melted. So with the stenosis, it's a narrowing because you have that plaque or something on the side or something along that line. So it's an obstruction due to the valve cusp thickening. The regurgitation is just that. It's backing up. So something's going through, but because that valve is not closing all the way during the cycle, there's a backup into the preceding cavity. And that's going to cause problems as well. So the first thing we're going to talk is about mitral stenosis. Mitral stenosis is just that. As I said, it's progressive thickening, it's a narrowing, and because of that, you have some contraction of the mitral valve cusp. This is actually what it looks like. So you have your normal valve, and you see how they're nice and open. Yeah, they're nice and open there. Now when you have that narrowing because of calcification or whatever it is, so here you have all the blood going through, it has plenty of room. Now when you have, you might be getting, I'm guessing 30%, maybe a little bit more than that, obviously a little bit more here, but that's significant. So you have a lot that's not going through. So what happens is the amount of stenosis obviously determines how much you're getting. However, it could get worse. So pathophysical, again, from the patho, you have your left atria, your mitral valve, and then your left ventricle. So if it's not a hole isn't going through, if it can't get through, you have a backup into left atrium, correct? And over time, you have left atrial dilation. At some point, this could back up into the pulmonary system, and you can end up with right ventricular failure. So when you have chronic mitral stenosis, meaning they've had that for a long period of time, that's when you have that right CHF. It's going into your pulmonary bed. You have a decreased preload. Cardiac output obviously decreases. With that, you have obviously your decreased tissue perfusion. And in the end, it's just not good. Pulmonary congestion, a little bit. This patient also would end up with the pulmonary hypertension after a while because of that backup. One of the main causes of this is your rheumatoid or your rheumatic carditis. Calcification, as I said, because as a patient gets older, you have more calcification. So sometimes something as simple as a cath might help a little bit, but not a whole lot. Other things that cause it, lupus, you could be born with it. And for some reason, it's more frequent in females. So again, these leaflets, they can fuse together, they become stiff, and you just have a narrow opening. Normally, you should have like 3 cusps there. In between those cusps, you could have 2 though. In between those cusps, obviously you have some type of opening, so it's like a flapping sensation. However, if they fuse together, that's when you have the problem, because again, they could be backing up, or they're causing that narrowing because they fuse together. So now you have that narrow opening. This is the picture. Okay, so what are your symptoms? Go ahead.
So because of the stenosis of the specific valve or the plaque or whatever the hardening, it regurgitates through the left atrium.
It's not regurgitating. It's because regurgitation is totally different. Because the opening is so narrow, everything that's normal, because you still have your normal cardiac cycle. So it's still going to be open for that amount of time, but that opening is more narrow, so you're not getting it through. So it's staying in the left atrium and not going down into the left ventricle.
You said before that it eventually causes right ventricular failure?
Chronic, if it's chronic mitral stenosis, that's when it's going to do it. Initially, it's going to take some time, so you're going to have the dilation of the left atrium. If it continues, you have that backup, all right, you have the big, and then it's going to go into the pulmonary bed and go into your right CHF, if it's a chronic problem. Does it make sense? It's happening over a long period of time.
So if it's a chronic problem in that situation, where it backs up all the way over to the right, then we have to take into consideration the left and right system, right?
Yes, yes. So what do you have because of that? Because you have the fatigue, the shortness of breath. Why do you have the shortness of breath? Because it reduces lung compliance, because again, it can be going into the pulmonary beds. Because that blood because it's not going through, so you have a backup into that left atrium, not a backup, but an accumulation, that blood's there. So you have hemoptysis. When they cough, you can get that blood tinged sputum related to that. With that you get respiratory infections. A major complication of most of these, but this one for sure, is your atrial arrhythmias, and more often than not, it's the atrial fibrillation. So now you have AFib. You already have a backup of blood into the left atrium. So you need to treat that, because they have a high chance of throwing a clot and having a stroke related to that. With this, be familiar with your sounds. You have a loud S1 and a rumbling apical diastolic murmur. You have exertional dyspnea, the right ventricular failure, as I said. PND is the paroxysmal nocturnal dyspnea, and that's at night. At night for some reason you get very short of breath. You have the orthopnea. How do you measure orthopnea? Is basically it's based on pillows. So some people initially they might maybe they normally sleep on 2 pillows, but when they sleep on 2 pillows, they're no longer comfortable, so they might have to get bigger pillows, and they might get to the point, some patients, and I've actually seen this in the home, where they can't even sleep in a bed anymore. They're now sleeping in a recliner because they can't, lie back and be comfortable. As I said, because of the backup into the pulmonary system, you have that pulmonary hypertension, and the first symptom in mild early mitral stenosis are usually they're precipitated by exercise. So this patient, you're going to tell them they can't exercise a whole lot. Obviously, they have to exercise some, because if they don't, they have to move. If they don't, remember, as a patient gets older, they become more stiff and everything. So on top of being short of breath all the time, they're going to be stiff and have a lot of pain. Other things, symptoms, emotional stress, infection, and fast AFib is the first one. So that's why when somebody comes in with AFib, they do so many tests, because many things could have caused it. They'll do a test for the valves and everything. Rheumatic mitral stenosis, obviously that's the mitral stenosis occurring because of the history of rheumatic heart disease. So what happened is Normally that valve is funnel shaped, but what happens is because of deterioration, it looks just like that. It looks like a fish mouth, and that's what they call it, a fish mouth. And like 25% of these patients have pure mitral stenosis, and 2/3, this is more common in female. So how are they going to diagnose this? As I went over some of the tests before, the echo, all right, and that echo is going to show you how the valves are, how they form, the morphology, are they fused together, are they thick, the degree of thickness, are they moving? They're going to look and see how they're moving, are they going back, are they opening up, and is there calcification in there that's impeding that? It's going to give you an estimation of the left atrial size. Why? Because continuous backup can cause that left atrial dilation, and they can also do a Doppler echo. That's going to estimate the area of the mitral valve, and it's going to tell you pulmonary artery pressure. So treatment, initially this patient might not be symptomatic, okay? So if they're not symptomatic, they will monitor them, but if they, and put them on medication if necessary. They're going to tell that patient to avoid any unusual physical stress. All right. So again, they can exercise, but once they get to the point where they're getting over fatigue, they have to stop. So it's important that they, as a nurse, you're teaching them frequent rest and activity periods. Once you start to get, very, very tired, or you start to get very, very fatigued, you need to stop. Salt restriction, diuretics, to bring down so you're not retaining fluid on top of that. You're going to give them medications again because this patient with the stress, they're going to have a higher heart rate. So they might be on your ARBs, your ACEs, your beta blockers, your calcium channel blockers, and everything. If they have a history of AFib or anything, you're going to give them the anticoagulants, and they have to follow up. If it starts to deteriorate, they're going to do the echo and work them up for other procedures, which we'll talk about. Any questions about mitral stenosis?
Yes, sir. What do we give for the arrhythmias?
The arrhythmia, you give them whatever, the beta blockers. It depends on what they're taking. If it's AFib, they might get something like amiodarone. We really haven't gone through this, but they might get the amiodarone or other antiarrhythmics. Definitely they're going to get anticoagulants. This patient does need, like you said, the antibiotics. Most of these need antibiotics prophylactically because even if they don't have a history of rheumatic heart disease, because those leaflets aren't working right, they can have bacteria or vegetation on them, and they can develop some type of endocarditis. So most of these patients would need antibiotics, especially before a dental procedure. And that's what I want to stress. Not so much, it's not antibiotics before any procedure. Like if they're having like something like a colonoscopy or something lower GI or something like that, they don't need it. Definitely they need to have some antibiotics and be cleared from the dentist before any dental procedure. Any other, because Nasia, on here, to control the heart rate, beta blockers or DINCH, okay? You also would have your calcium channel blockers. Anticoagulants, obviously you're going to have your, more often than not, it's going to be either your warfarin or some of the other ones. Some of them you can't use the non-traditional, which we'll talk about. So that's how you're going to treat them. If you want to increase the contractility, if you can give them, some DINCH, but again, all this has to be monitored. You have to get digital levels and everything. Any other questions? Okay. Regurgitation is just that insufficiency, again, because it's not closing, the mitral valve is not closing, it's not getting a tight seal when it's going through, there's a backup from the left ventricle into the left atrium. So it's the failure of that mitral valve to close and seal during the end, at the end diastole. So it's not fully closed during systole. Some of the causes, one of the causes is your prolapse, rheumatic heart disease, trauma, lupus, endocarditis, and again, this is something that's more, for some reason, it's more common in females. So what happens is the leaflets are backing up into the atrium during systole. What are your symptoms? This has a very long symptomatic phase, asymptomatic phase. So you could have this for a long period of time and not have any symptoms. But after a while, you're going to start to exhibit decreased cardiac output. So what happens is, again, the same thing. You have fatigue, you have weakness, you have cough. One thing, you could have chest pain, but fatigue is always gonna accompany the chest pain. But please be aware, if any of these, nitroglycerin for the most part is not gonna help because the chest pain is not related to the heart, to myocardial ischemia. It's because there's a blockage there. So sometimes when you give them nitroglycerin, it's not gonna help. This patient is still gonna have the dyspnea on exertion, right ventricular failure, and everything that's on here. What's different about this one, you're gonna have a holosystolic, high-pitched murmur, okay? And these murmurs are basically noted at the apex. The apex is the same thing as your point of maximal, the PMI. So know that the apex and the PMI are the same. How they diagnose here, the same thing. They're gonna do an echo. And what does an echo do? One of the functions is to measure the functioning of the left ventricle, and it's going to show you chronic volume overload. What happens is you have a sudden increase in the pressure, and then you have volume overload, and the same thing happens. You have a buildup in the pulmonary beds. This patient would develop that pulmonary edema, and without proper treatment, this patient could go into cardiogenic shock. And then we know all the manifestations related to cardiogenic shock. They have the pulmonary edema, and at some point, because it's so bad, they're going to need some type of surgical repair. And again, your apex or your PMI is displaced; it's off to the side, and they're going to have those atrial arrhythmias, more common than not AFib. Surgical, you can be treated surgically. But surgery is indicated in the presence of symptoms or left ventricular and systolic diameter. It's better to try to do surgery, and the doctor obviously makes a decision. You want to do surgery before the patient is extremely symptomatic, because what happens is if you wait too long, the sicker you are, the lower your chance of having a good recovery. And they have various types of surgeries, which I'm going to talk about in a little bit, but you can have a repair or a replacement, or you can have something called a valvuloplasty, where it's actually a balloon that goes into the femoral artery, and it's a little better, but it doesn't last as long. So the surgical procedure, as it says on here, is either mitral valve repair or replacement. Repair better preserves the left ventricular function, and it avoids the need for chronic anticoagulation. However, it's more demanding on the body. Actually, hold it. Please, and this is my mistake. Replacement is more demanding, because replacement is actually the one where they go in and they do the surgical procedure where they open up your chest. Okay, so please make that replacement. Replacement is more demanding on the body. Okay, as far as prolapse, again, it's the mitral valve leaflet balloons into the left atrium during systole. So they might have some type of chronic problem, or it could be a genetic problem as well. As it says, it's a family tendency, more common in females, anywhere from 20 to 40. What happens is that leaflet, and again, the cusp, it balloons back into the left atrium during systole, and because of that, you have a backup. This is just the picture that shows you, one of them shows you the leaflet. Okay, this is the normal one. So you have the left atrium and mitral valve, and you see it's nice and open here. It's a little bit more closed, so you have a prolapse because it's backing in. So you have the blood backing back into up this way, actually, up into the left atrium with the mitral down here. This is also something the patient can be non-symptomatic for a long period of time, and however, when they start to get symptoms, they're very, very vague. So they might go to the doctor and have vague symptoms, and usually it's fatigue, it's dyspnea, dizziness, and they have that atypical chest pain. It's not chest pain. Again, it feels like chest pain, but when they do an EKG, they don't see a whole lot of changes. Again, because it's not related to the heart being damaged. It's related to them not getting enough blood in that area, so it starts to tighten because of that. They will have that exercise intolerance, because the more they go, the more tired they become, so they're not able to do it. They have those palpitations as well. Those palpitations a lot of time related to a new onset atrial fibrillation. This, again, the chest pain does not respond to the nitroglycerin, similar to what I said before, because it's not actually a tightening.
So what do you give for? What do you give for chest pain?
It's not chest pain, it's atypical chest pain. And you know it's atypical because if you do an EKG, what would happen if you do an EKG and they had a heart attack? You see some changes, right? What type of changes would you see? You invert T waves, you might see a STEMI, things along that line. Okay, you're gonna see some changes. Here you're not gonna see it. You're gonna try the nitroglycerin and they're not gonna respond to it. All right, if you did, if they do a catheterization, they're not gonna see a lot of blockage that will cause the chest pain. So that's why it doesn't respond, because it's not due, what happens, it's not due to an MI or that dead tissue. It's because they're not getting proper blood. So it's not related to so much oxygen, it's just because they're not getting enough blood. So that's why they have decreased cardiac output, because that blood's not going through. Make sense? It's backing up. Does that make sense to you? It's not related to the ischemia. This patient, you would again want to give the antibiotic. Why? Because you want to because there's a backup. Again, they can have some bacteria or they can have some vegetation there. So you want to give them the antibiotic before procedures and actually after, because you want to make sure that if they do have vegetation, they don't acquire bacterial endocarditis. So endocarditis is a big risk with a lot of these diseases. And that is important. How do you manage it? Again, you're going to give them the antibiotics prior to any procedure. Basically, your dental procedure, not your lower body, not your colonoscopy, things along that line. Avoid catecholamines. What are some catecholamines? What are some stimulants that you think they should avoid? I'm sorry? Who?
Caffeine.
Caffeine is one of them. Okay, what else? Alcohol. If they smoke, they need to stop smoking. Anything that's going to make you more hyper. The Sudafed. All these type of things that will make you more hyper. Any type of stimulant.
So no sex?
Say that. Say that.
If they're going to get overly excited, well, you would say with tolerance, they could maybe up to a certain degree. Nothing rough, nothing over excessive, they can cuddle, they can have, I guess, gentle sex, they can't have rough sex, okay? They can't be, get overexcited, anything along that line. I would say probably strictly missionary, and they probably and they probably need to be on the bottom.
Yes. Jumping. You can do the jumping. You can do the jumping, I guess.
Is that explicit enough?
You can do the jumping. You can do the jumping.
Other things that you would give them, the beta blockers, hello. They could be on their beta blockers or calcium channel blockers. You can increase their fluids somewhat. Why do you think you would increase their fluids? Because what would happen with this patient? What type of symptoms are they having? Because they're dizzy and they're having syncope, they could have orthostatic hypotension. So increasing fluid somewhat might help that. Okay. They would also be on long-term dose aspirin therapy, like your low-dose 81 milligram therapy. And if they have a history of stroke and with the endocarditis, they are again going to be on antibiotics. Any questions about that? Okay. So these are your treatments. Medical and surgical treatment options. Remember, from your heart failure lecture, a lot of these symptoms are similar to what you learned in heart failure, correct? Mm-hmm. Okay. So, if it's heart failure, how are you going to treat them? The diuretics, the digoxin. If they do have the AFib, again, the beta blockers, the calcium channel blockers, low dose amiodarone. Your amiodarone is used when they have a rapid beat. So amiodarone is like if they start to have a very, very rapid beat, amiodarone is not approved for, unless a patient has a history of that. If they don't have a history of those rapid lethal beats, then it would be something called dronedarone, which is the Multac, and the Multac is indicated for AFib and A-flutter more so. Okay. However, the other thing is the newer anticoagulants, like the Xarelto, the Pradaxa, the Eliquis, they do not want you to give this patient an AFib bed. Why? If they have a valve problem, why? There's no way to monitor it. What happens with Coumadin? You can monitor it. The newer ones, the Xarelto and everything, there's no way to monitor them. I mean, they're good, but when they start having complications, some of them you have to pump out with dialysis. Some of them you can't even get out the system with dialysis. So they're good, but they, you know, everything that's good has a side effects. You want to treat the symptoms as they present with them. Again, as I said, the beta blockers, and if they're symptomatic, they would benefit from these therapies. Options, you can also have surgery. Your surgery can be invasive or non-invasive, all surgeries though. So the non-invasive surgical one is the balloon, and that looks like this. So basically it's called a mitral valve valvuloplasty. And what they do is, the beauty of this is only invasive because you go in through the femoral artery. All right, you do not have to open the chest for this. So what happens is they go into the femoral artery, they thread it up to the area where the mitral valve is, and they take a balloon and open up that balloon to separate those leaves. Hopefully with that, that's gonna open that opening a little bit more. So you see how you see the balloon going in through that? That's what they do. It's open, and this is actually good for the patient. It doesn't take as long as an open heart surgery would. You have a decreased chance of infection. That's not saying you can't get it, and you're discharged a lot sooner because of it. This is considered repair, not replacement, because they're not replacing it, they're only repairing it, but repair is not gonna last as long as replacement. All right, so again, it has short-term effects, much shorter when it's the aortic valve that they're doing, but they can do other stuff with the aortic valve, which we'll talk about. So it's more common, but it's not, it's not long-term, but this is better for your patient who might be at higher risk if you went in and did open heart. The invasive is just that, it's open heart surgery. So maybe they went in, they did catheterization, they found some blockage as well. So they're gonna do a catheter with a mitral valve replacement, okay? The mitral valve replacement is called the mitral valve commissurotomy. And it cuts the leaf, it actually goes, they cut the leaflets and it widens the opening. And then they go ahead and they replace them. So again, this was the picture for the valvuloplasty. With the valvuloplasty, as I said, they put in a balloon and they open up those areas. It's a shorter hospital stay, as I said, less pain, lower risk of infection. And a lot of times they can do this robotically now. You know how they have robots doing it? So this can actually be done robotically. Obviously, there's somebody behind that robot, manipulating it, I should say, but it can be done robotically. So what are some of your major nursing interventions related to this? It's important, this patient is having a procedure, so anytime they're having a procedure, you need to do baseline. You always want to do a baseline neuro with this. Why? Because it involves the atria, it involves fibrillation, you can have some backup, you can have clots in there. So you want a baseline neuro assessment, so God forbid they do throw a clot. You've documented they were alert and oriented prior to this, now maybe they're disoriented to some time or something along that line. Respiratory assessment, how are they breathing prior to the surgery, how are they breathing now? Tell them the importance of alternating rest periods, of being compliant with their medication. Monitor their volume signs and monitoring any edema. And this is just, a picture showing you the closed valve. This is your closed valve, and that's your prolapse valve that goes back in, okay? Any questions about that? None? Okay. Now we're going to talk about the aortic valve disorder, similar to the mitral valve. Here you have this picture you know, and it's just showing you the way the valves are and everything. You can have 3, you can have 2. It's not common to have 2, but some people are informed with only 2. For the most part, you should have 3 there. Aortic stenosis, again, it's a narrowing of the aortic valve, okay? And what happens is because of that, you have thickening cuffs. Precursors to this are people with syphilis, which isn't as common now. Again, if they have a history of rheumatic fever or any type of endocarditis, it's more common in people, older people, again, because of calcification. As we get older, you have more calcification and fibrosis. There's a higher incidence in smokers and people with hypertension. Diabetes and hypercholesterolemia are common causes as well. So these are your leaflets pretty much. You see the 3 valve leaflets, see how nice and open that is? It's nice and open, and these are 2 valve, they're nice and open. Okay, so with you know, any type of stenosis, it would be much narrower, and because it's narrower, enough blood, a lot of blood is not going through. As far as the patho, it's the same thing. Because of the backup from the left ventricle to the left atrium, because it's narrow and obstructive, you have obstruction of the blood from the left ventricle to the aorta at this point. So now you're going from the left ventricle to the aorta. So it's going through that aortic valve, and it's not passing through the way it should. And with that, you have again it's left ventricular hypertrophy, and you can back up more. The key with the aortic stenosis, the key physical findings are SAD. What's SAD? Syncope, angina, and exertional dyspnea. Okay. The gold standard for this is catheterization, because that's going to confirm that there's an increase in the right side of pressure. And again, what happens when you have an increase of the right side of pressure? You have that pulmonary congestion, and that backup there. And more, because you have right side of failure, what type of symptoms do you have associated with right side of failure? JVD, exactly, all that swelling, ascites, exactly. Here you have a reduced systolic pressure and pulse pressure. So as we talked before, you have that narrow pulse pressure associated with aortic stenosis. The murmur here is a crescendo, decrescendo murmur. It's hard to identify murmurs. You know, it's hard to hear them unless you have like a trained ear. But what happens is it's more prominent when if you have that patient leaning forward, and you hear it at the apex. Prominent S4, and that's related to a forceful atrial contraction. And if you did an EKG or echo or anything, you're going to see a left ventricular hypertrophy, and they're going to have some AV node conduction issues, which is why they also have the AFib, and that's related to your calcification. There's also, now with this, it doesn't, they do give the nitro sometime, but if you give it, you have to monitor that patient very, very closely, because it's going to cause or make the cardiac output even less. It's going to exacerbate it. And you can develop dangerous hypotension. They might always have hypotension. So it's really contraindicated, but I've read in the literature that they do it. I'm asking you to remember it's contraindicated, all right? If you're going to, but that's the next question. What should you know? Okay, so it's contraindicated. As far as aortic regurgitation, it's the same thing as insufficiency, and it's a failure of that aortic valve to close and seal. So just like before, the mitral valve wouldn't seal, this time it's the atrial valve not sealing. And because it's going from the left ventricle to the aorta, again, you have that initial backup in the left ventricle causing that left ventricular hypertrophy. These are the different causes, similar to what was before. And this one is more common in females. I'm sorry, in males.
I'm sorry. The slide before, you say if you give nitro, you have to monitor it. Why?
Because it's contraindicated when you're worried about hypotension.
Okay.
Severe hypotension.
Okay.
And they already could have a low blood pressure from everything else, so you're worried about severe hypotension. Okay, so the pathway of this is just that. Normally, once the blood goes, you go from the left ventricle to the aortic valve to the left atrium, to the aorta. but because there's a backup or there's something backing up, it's gonna back up into the left ventricle, and because it's backing up there, you have left ventricular hypertrophy. And it can continue to do it, but initially you're gonna have that left ventricular hypertrophy. Make sense? Okay, so the blood flow back into left ventricle from the aorta, it hypertrophies and dilates, and what do you have there? That raises your systolic blood pressure. With this, you have a widened pulse pressure, which is what? The arteries try to compensate by dilating, and that reduces your diastolic blood pressure, and because your diastolic blood pressure is reducing, you have a wider pulse pressure. With that, you have the regurgitation causes a high-pitched diastolic murmur. So what are your most common symptoms? Well, initially it happens in your 40s and your 50s. Just like the other ones, you have that fatigue, your orthopnea, the dyspnea with exertion. As it progresses, you're going into right ventricular failure, so you have your pulmonary congestion, and it's severe when it gets there. Hypotension, and that's because of the decreased stroke volume. And again, this is something you would not want to give that nitrophysiol for because they're already hypotensive, trying to compensate. That wide pulse pressure. There's something called a water hammer pulse. It's also known as a Corrigan's pulse. And that's because there's pressure within, so it has like a loud sound when you hear it. Same thing, same diagnostics, the EKGs, the chest x-rays, and the echoes are going to show you something. And again, that hammering sound is because you have prominent carotid artery palpitations. Okay, so treatment, similar to the other one, you have medical, non-invasive, and invasive. If it's just heart failure, they're not really, really bad. You're going to treat the symptoms related to heart failure. What do you want to do? As in everything, you want to increase tissue perfusion and increase cardiac output. You want to teach that patient, if they're monitoring initially, regarding lifestyle changes to decrease symptoms and increase cardiac output. Obviously, you want to teach them, to be compliant, that they have to alternate resting activity periods, salt restrictions, all those things. Just similar to before, invasive, the surgery is the valvulotomy, and that's a repair. It's palliative, or you can have valve replacement, which we will talk about again. How do you manage it? Exercise testing with symptomatic patients causes arrhythmias, so you exercise. A lot of exercise is contraindicated. They cannot exercise for long periods of time. They can do gentle exercises. Nausea, maybe have gentle sex, okay? The valvulotomy is similar to the other one, the valvuloplasty, where they go into the femoral veins. They can have an aortic valve replacement. That's your traditional one where you cut open the chest. Or they can have the newest procedure called a TAVR, where they go in through the the femoral artery. So if it's just medically and you want to, and your monitoring is not really, really bad, you give them the drugs to treat and control the symptoms related to the heart failure. So your vasodilators, if they can tolerate it, your nitrates, however that's contraindicated with your stenosis, your ACE inhibitors. Questions? Diuretics, your DINs, everything that you give for congestive heart failure, your beta blockers, calcium channel blockers. Again, teach them about sodium restrictions, teach them the importance of weighing themselves every day, same time and about the same amount of clothes, calling the doctor if they get, if they retain too much fluid, anticoagulant, and antidysrhythmic based on, how the doctor, the doctor orders. All right, so what are some of the options as far as surgery? The valvulotomy or the valvuloplasty are the same thing. So if you see either one, they're the same thing. In some books it'll say valvulotomy, in some books it'll say valvuloplasty. But again, it's going into the femoral vein. The balloon is initially deflated. It's going to go all the way up until it gets up into the area where the valve is, and then it's going to they're going to open that up to open that area up. Again, that's only temporary though. It's more palliative than anything. So what happens is for a short period of time, they are gonna have increased cardiac output, they are gonna feel a little better, they are gonna tolerate exercise and everything, but again, it's short term, okay? It might last 6 months, if that. Sometimes, you know, it's good if a patient wants a better quality of life for a short period of time, but at some point, other things are gonna have to be done, or, you know, death could happen. They need lifestyle changes. Now, the invasive thing is that the aortic valve replacement versus the TAVR, all right? The TAVR, as I said, it is the newest thing. That's for your patient who has a higher risk of having complications if you open their chest up. So there's a lot of factors they have to consider, you know, before they do that. These both are, they are replacing the valve in both of these. It's just in one they're going into the femur. But this is gonna, the symptoms are gonna get better, but depending on how long they've had the symptoms, they still might have some dilation of that left ventricle. Remember, the body, it's like the heart's like a rubber band, so it stretches and everything. If it's been overstretched for a longer period of time, it's not just going to pop back into place because that rubber band has been stretched well too much. So sometimes they might try to do a balloon procedure first to see what type of quality life they have, see if they can stabilize that patient, and then maybe they can do some type of replacement. But this patient also has to be on short-term anticoagulant therapy because they're going to monitor it. A lot of the complications of these are, again, AFib. So the TAVR, what is that? It's the newest, and they're still expanding. They're still doing a lot of research. It is, traditional AVR is still the gold standard. It's developed for, but the TAVR, which is the transcatheter aortic valve replacement, and the good thing is they're replacing the valve, all right? They're not repairing it, they're replacing it. But it's for your high-risk patient who, you know, if you actually opened them up and did surgery, you know, they're not gonna fare well. They might have a history of diabetes, so they don't heal well. They could have other issues, so they're not a good candidate for your traditional aortic valve replacement. So again, this is going up through the femoral artery, through the aortic arch, and up to the valve that's narrow. As I said, the valvuloplasty is your other option, but you know, 6 months maybe. Overall, if this is successful, the TAVR, they do have a good quality of life. I actually had a patient who had this. She did very, very well. But what was interesting, probably about, I'm gonna say after a month, she developed AFib. Her heart rate started going up. She went to AFib. So they ended up putting her on, I think it was Coumadin, and then she had to go on metoprolol because her rate was going up. It's a collaborative approach, so you have your cardiac surgeon in there, you have your nurse and everybody. But again, you still have to monitor for infection, and it's just that site for delirium because of decreased cardiac output, it can, and arrhythmias. The major complication of this is your stroke because for some reason they had an irregular heart rate and they had some embolic activity going on in there, or they already have clots. You can go in there and once you touch that aortic valve, just lodge one and they can have a stroke on the table. With a AFib, depending on their rate or anything, they might have a need for a pacemaker and or an AICD, which is an automatic implantable cardiac defibrillator, which we'll talk about actually on Thursday. Other complications, they might have that retroperitoneal hemorrhage that's characterized by what they will have a lot of bruising right in their kidney area. And it's not from a heparin shot, it's because there's internal bleeding. And they might have something to develop of a pseudoaneurysm, which is just a false aneurysm. So this is just informational. It tells you, how they, the patient is a better candidate for surgical aortic valve replacement and the one that's better for the TAVR. It's just, for you to see. Now with replacements, when you replace those valves, you have mechanical valves and you have biological valves. The one thing is when you have a mechanical valve, please remember this, the mechanical valve will require anticoagulation for the rest of their life. Okay? Those who get the biological valve, usually it's for about 3 months, and if they don't have AFib anymore, which they should be good. So the mechanical valve will be on anticoagulation for the rest of your life. The biological valve will not.
Only for 3 months?
About 3 months.
Oh, okay.
All right, about 3 months.
Okay.
The valves, as I said, you have the mechanical, you have the bioprosthetic, which are your biological ones. They might be pork valves, they could be pig valves, yes. You know, they call them Carpenter Edward valves, so they're different type of valves. The mechanical valves have very good durability, but they require long-term anticoagulation, and they can cause hemolysis. So if you're thinking of the patient, what type of patient is better for your mechanical valve, and what kind of patient is better for your tissue valves? Hmm?
But no allergies. Something.
Somebody say something.
Less
Allergies.
complication.
I'm sorry?
Less complication.
So what type of patient is gonna have less complications?
Younger, healthier,
So, and what valve would you rather give them?
a file,
And why?
they will live longer.
Because it's for short time and they can do the valve is for short time.
If it's a younger person and they're compliant, they're better for the mechanical valves because they're gonna remember, with the mechanical valves, you're gonna be on anticoagulation for the rest of your life. All right, your older person who is forgetful, I'm not saying everybody's forgetful, your patient with dementia, your patient, obviously your pregnant patient or anything like that, they're not good candidates again for your mechanical valves because they have to be anticoagulated for a long period of time, forever, pretty much. So your healthier patient is gonna be, or your younger patient, your more compliant patient is a better one for your biological tissue valves.
What?
I'm sorry.
Mechanical.
Mechanical valves. Mechanical valves. Your biological valves have a limited durability, and again, you only need to be coagulated for the first 3 months. If you have an older person where they have a family member, you know that family member is watching them, is going to take them in all the time to have their INRs monitored and everything, then that's a consideration. That's only with your, that's rare, but it's not unheard of. So what are some of your interventions, for invasive, or, I'm sorry, this is talking about the valves. You don't have to know this, but there's different type of valves. So if it's an allograft, it came from a human donor, so that patient is probably no longer with us. The xenograft is from an animal, a pig or a cow, and the other ones. They can make something called an autologous one, and that's made from another tissue of the patient. Not very common, because that's going to take some time, but these are just the different types of valves. In addition to those for bypass surgery, so when Mrs. Farber went over about bypass surgery, she told you some of the complications related to CABG, correct? Infection, what else? AFib, what else? MI, all that, okay. So in addition to that, they're at a high risk for emboli because of the turbulent blood flow around the metallic parts, more common in the mechanical valves. So they're probably in the hospital, they're gonna go from heparin, reheparinize it to convert it to Coumadin. And sometimes you do have patients, and you see it a lot more now, who are on your Coumadin and your aspirin. Another one, you can have even though you replaced it or you repaired it, you can have an incompetent valve, so it has to be monitored very, very closely to make sure it's doing what it's supposed to do. The patient is supposed to be healthy now, have an increased cardiac output. Other than have maybe a little bit of AFib, they shouldn't have a whole lot of symptoms. So if they're still, if the vitals aren't what they should be, if they're still extremely fatigued and everything, they have to go and do some tests and see what's going on. And again, endocarditis, this patient also should be taking some type of antibiotic prior to dental procedures. So your goal here is obviously increase tissue perfusion, and you want them to maintain adequate cardiac output. So again, if they took the mechanical valve, what are you looking for? Therapeutic INR. What's your therapeutic INR?
2 to 3.
It's 2 to 3. I've actually seen it, I know it's a little surprised. Today was 2 to 3, but I actually saw in a book this week where it said 3 to 4. You want to follow up with the symptoms, teach them about the meds, the importance of taking the meds on time, the importance of monitoring their vital signs, exercise, alternating resting activity periods, diet. They still should avoid caffeine, alcohol. We should all do Sudafed. They should be monitoring their weights all the time. Support Teach them about foods that are high in vitamin K. So what are some, and why are we teaching them about foods high in vitamin K?
It's a blood product.
Because of the coumarin. And what are some foods that are high in vitamin K?
Green leafy vegetables
Okay, so such as,
like spinach,
no, you're thinking potassium, not vitamin K. Potassium.
I'm sorry, I'm sorry.
green leafy vegetables.
Did you not hear me say banana? Did I say no? What you say? Vitamin K, your spinach, your Brussels sprouts, your broccoli, your kale, your collard greens. Believe it or not, beef liver has a lot as well. So things like that are high in vitamin K. So and so what type of referral? Obviously a nutrition referral, sometimes a social worker, for code and things along that line. And they also, it's a good idea to teach them to wear that medical alert bracelet, because God forbid something happened and nobody's with them, we need to know they're on coumarin if they're going to be rushed to the emergency room for whatever. If they did have an open heart procedure where they did did the valve and open heart, you want to teach them the signs and symptoms of infection, to monitor that for bleeding, pus, opening, all that. If they had that as well, what happens? They can't drive for how long? Did she go over this?
What did you say?
I'm just asking. With cabbage, you can't drive for how long? 48 hours. No. You can't drive for like 6 to 12 weeks. Okay, and why? Cabbage, they just open your chest. Okay, they open your chest and expose all this. Now they closed it, but that's still very tenuous, very delicate material. So say you're in the car, and you really shouldn't be in the front seat either, because if that airbag explodes, you explode with it, okay? You die. All right, so you can't drive for 6 weeks. They tell you no lifting more than 15 pounds for about that same, 6 to 12 weeks. Those are very, very important teaching to your patient. At some point, once they get cleared, when they go back for that initial 6 week, the doctor might start cardiac rehab, and obviously you're going to a rehab and they're monitoring and everything. But that driving and that being in the back seat, that is like very, very important. So how do you evaluate how they did? If they're doing well, if they have adequate tissue perfusion, if they have, if the fluid electrolytes are good, they can be a little bit more active than they could before, but again, they're working up to that point. It's not going to happen overnight. They understand what they're doing. They can tell you why they're taking their medications. If they're taking DIG or something like that, they can monitor their own pulse. They know the importance of weighing themselves every day. And they know that, they shouldn't eat, and it's not, I know a lot of times we say avoid, you don't want to avoid vitamin K, you just can't go over how much you normally take. Like if spinach and broccoli is part of your diet, you keep that amount in there, give or take a few, because your PTINR can be affected by it. So, you want to stay up this, like you just don't want to binge on the iceberg lettuce and everything. But if you're a salad person, you can stay with that, okay? But you just don't want to make changes where you take a whole lot more. Does that make sense?
Professor,
Yes.
can I ask you something as it relates to cabbage? I am wondering, there are two types, right? You have the off pump.
You have off pump and on pump, yes.
And on pump, right?
Yeah.
So one of them is least invasive because you go in.
Off pump is more least invasive.
Right? So that one, you have a different duration as it relates to.
You have a different what?
I'm trying it, I'm trying it. I know it's two of them. I know the pump one, because of the bypass.
The pump, on pump is just that on pump. That's where they cut you open and everything. You have higher risk. You're in there longer. You have a higher risk of infection, a higher risk of. In both of them, you can get AFib, but you're more likely to get AFib with that. You're going to have more pain. You're going to be in a hospital a longer period of time. You're going to have a longer period. Whereas the off pump, that's why some people like it, and some people can't tolerate it on pump.
Yeah, I'm just trying to because of the I know that I saw 48 hours for one of them, so I'm just trying. I know that could not be the
Maybe the off pump 48 hours because they didn't cut your chest.
Right.
All right. But I still, even if they had any type, I don't think anybody should be driving 48 hours after surgery unless you had a colonoscopy, and that's just because because all they're giving you then is some type of drug. All right, so anything with your heart, I don't think you should be driving 48 hours later. But if that's what she told you, that's fine.
No, I said we didn't touch.
It's probably that one, because on the arm pump, the open one, you cannot drive for about 6 to 12 weeks. I'm 200% sure of that, okay?
Thank you.
All right, so here's a brief case study. So this man, he's a 72-year-old man who comes to the emergency room complaining of dizziness and dyspnea. He has a history of hypertension, MI, he has a pacemaker, infective endocarditis, and MRSA. What factors of his history put him at risk for valve disease?
Jason.
Okay, his age. And what else? Endocarditis and what else? Hypertension and the fact that he has a history of MI.
Yes.
Okay. They do a physical examination. He has a loud systolic murmur at the point of maximum impulse, left ventricular line. A chest X-ray shows fluid in his lungs, so he has some backup already. The healthcare provider suspects that he might have mitral regurgitation. So tell me, one person, tell me the pathophysiology of mitral regurgitation.
When the mitral is not closed or sealed.
Right. But tell me about the patho though. What happens?
With the mitral, we have it at the left side, left sided heart. So it's like if the mitral, so the blood that is coming from the atrium has to go to the left ventricle. So in this case, if there is it's not sealed well or closed well, it goes back. And when it goes back, it can go into the pulmonary.
Well, first it's going to the left atrial. So you're going to have left atrial dilation, and then it's going to the pulmonary, so you have pulmonary congestion, pulmonary hypertension, all that. Good. Okay, so what additional clinical manifestations of mitral valve regurgitation would you want to check him for? What other symptoms would you suspect with that?
Dyspnea.
Hmm?
Dyspnea on exhaustion.
Dyspnea, okay. What else? Think of heart failure, fatigue, weakness, cough related to what? The back of the tube. So with that cough, what else might you see? Hemoptysis. So you're worried about pulmonary edema as well, correct?
Mm-hmm.
Okay, so what treatment would you expect the healthcare provider to order, and what dysrhythmias is he at risk for? With his age, is he a good candidate for repair or replacement? Repair, because he's older, he might not remember to take the pulmonary or something like that. Okay. And what dysrhythmia is he at risk for? AFib. Right. Okay. So initially he responds well to medical management. However, he's still having repeated hospitalizations related to heart failure, and his mitral regurg progressively worsens. They talk to the cardiovascular surgeon. They recommend a mitral valve replacement. He asked you whether he should get a mechanical or biological. How do you respond? And why?
I can't remember. So he's
The medication. They give them. They give biology.
Oh, so you need to get this?
What's wrong?
Okay, you don't want to give him the mechanical because you have to be anticoagulant for life, you can medical for biological.
For life.
Based on age, dementia, things on that. He successfully undergoes the replacement with a mechanical, they use a mechanical valve. All right, what teaching will you provide for him? The need for long-term anticoagulation, okay? He's gonna have to go, lifestyle changes, he's gonna have to go, initially they're gonna give him INRs every 2 weeks. probably every 2 weeks or so. But then after that, not as often. Once he gets stabilized, they won't give as often. But what do you need to teach him? The signs and symptoms of bleeding, like if you're coughing up blood, if you're the breathing of the gums. If you hit yourself and you bleed too much, then you want to let them know. And it's important with the elderly because the elderly have entered the ER with INRs of 7. I've seen somebody with 9. Okay, so yeah, I was at the VA one time and like this man walked in. They said his PT or his INR, and I was like, oh my god. And obviously, they have to reverse that right away. How do they reverse that?
Vitamin K?
Vitamin K. Any questions about that? Any questions about mitral valve, aortic valve, surgery? No?